everyone. Welcome to Hernia Talk Live. My name is Dr. Shirin Towfigh. I am your hernia specialist every week on Tuesdays on our live sessions for Hernia Talk. You can follow me on Twitter and Instagram at HerniaTalk. On Facebook, many of you are joining us live at Dr. Towfigh. Thanks to those of you that are joining via Zoom. And at the end of the hour, I'll make sure you can access to share this session on YouTube. Today's guest panelist is Dr. Justin Houman. I hope you enjoy this hour because he's young and he's very fun, and the topic is quite interesting for most men who undergo hernia surgery, and that is going to be the discussion about male fertility and hernia surgery. Dr. Houman is a urologist and male sexual health and fertility specialist in Los Angeles. You can follow him on Instagram and on Twitter at Justin Houman MD. So let's welcome Dr. Houman. Hi there.
Hey, how are you?
Good. Welcome.
Thanks for having me on.
So I know you because you trained at Cedars-Sinai and also did extra training in they loved you so much they brought you back. We've had Dr. Joseph in our Hernia Talk Live before. You've joined his group, and I'm super excited to be able to work with you. So for those of you that know me, know that I do a lot of joint procedures and work with many different specialists. I bring a lot of them on to Hernia Talk Live. Dr. Houman is one of them. He is a urologist, and I feel that because of your specialty, you could add so much to our guests, to our viewers, because I don't know, like when I see patients, they always are worried that how will this affect my fertility? How will this affect my sexual function if I have hernia surgery or mesh removal? So I hope we can answer some of those questions today.
Absolutely. Yeah, we have plenty of good answers for these questions.
Okay, so I do have some questions that have been presented before already, and then as they come in through live, I'll have you answer others. But maybe first you can quickly describe how your training is different than other urologists.
Yeah, so all urologists, the training is you go to medical school, you do a residency, anywhere from 5 to 6 year residency. Your first year is general surgery, and then you do 4 or 5 years of urologic training. And then at that point, so historically, decades ago, that's all a urologist ever did. And then you went out into the real world and you practiced medicine. You saw all types of urologic issues: kidney stones, prostate cancer, urinary incontinence, and the such. And then now, as people get more specialized in training, we have subspecialties within urology. So prostate cancer, as Dr. Joseph, he's a robotic surgeon, deals with prostate cancer. There's oncologists, pediatric urologists, female urologists. So my field is men's health, it's primarily male infertility. So I deal with sexual issues as well as reproductive issues. Very few, it's a growing field in urology. When I applied, I think there's only 12 spots in the nation. Wow. Now there's maybe 20. So it's growing. It's obviously there's a need for this because men don't have, previous generations of men never really discussed these men's health issues, and now they are. So we're filling that niche. So men's health specialists like myself, we're filling that niche. And
you only treat men, right? You never see a female in your office?
I do. I do general urology as well. So I definitely see, the bulk of my practice is men's health, but I see all types of general urology patients as well. So females.
And what's the age group?
For the men?
Yeah.
I see patients as young as 18. Some of those guys have erectile dysfunction, all the way to guys 97.
Yeah. In Los Angeles with their 20-year-old wife.
Yeah, who are trying to have a kid. So it's a broad range. But yeah, there's a lot of young guys who have erectile dysfunction. So I see them young.
Okay, so what is erectile dysfunction? What's the actual true definition of that?
The truth, the layman's way of saying what it is basically if you're unable to attain or maintain an erection that leads to satisfying intercourse. So some guys are able to have a strong erection. Some guys are able to gain an erection, but they're unable to maintain the erection.
Okay.
And ultimately, what it comes down to is if you're not really happy with the length, duration, the whole experience of intercourse, then due to the strength of the erection, then I would say, listen, you should see somebody to address that erectile dysfunction.
Okay, and then can hernias cause erectile dysfunction? I get that a lot. They say, oh, I have this hernia and, it's a cause of my erectile dysfunction. But I feel like often what they really mean is they have a hesitancy
Exactly.
for erection. Like functionally they can do it, just a hesitancy because they maybe have pain from their hernia, right?
Exactly right. Exactly right. So there's no, to have an erection, you need four things, right? You need good blood flow, you need normal hormone levels, you need a good nervous system, right? The connection between the brain, the penis, everything has to be connected. And lastly, you can't have any anxiety or any stress associated with it. So when you're talking about the things of hernia, I think it comes down to that fourth one,
Right.
that performance anxiety, this thought in your mind that potentially this is not I'm gonna have pain, I'm gonna have any type of distress. And the thing is, you can't have any stress because those hormones are gonna crush your ability to have a good erection.
So there's medications for that, I assume, right? All was it the blue pill?
The blue pill, yeah. There's the blue pill, Viagra. There's Cialis now. There's tons of things out there, right? And I always say, I promise you, some way, somehow, if a guy comes in, he has erectile dysfunction, I promise you, some way, somehow, you're going to get a good erection, but it all depends on how aggressive you want to be, how invasive you want to be. We have pills, we have injections, and then we have surgery. So, and along the way, there's different things that, various new treatment options that are coming out that regenerate the penis, that take it back 5-10 years. There's shockwave therapy, there's PRP for the penis. All of these things. And, in the next 5-10 years, there's going to be a lot more advances as well. So I promise you will be able to have an erection some way, somehow, if you are experiencing erectile dysfunction.
Okay, so if they have a painful hernia and they have erectile dysfunction because of it, will Viagra or some medication help with that, or you have to fix the hernia?
It could. The Viagra, the pills could definitely. It all depends, right? If your source of the erectile dysfunction is the anxiety and the stress associated with the act of intercourse, then the pills could take you to that next level and avoid and basically give you a good erection, even if you are having some anxiety. But it's definitely worth a try, right? I would start off, anybody who has a hernia, who's experiencing erectile dysfunction, that's where I would start for sure.
Wow, okay. As you know, most of what I do is revisional surgery, so they don't actually come to me with a hernia, but they've had a hernia repair and there's a complication from it. And then they feel that the hernia repair caused erectile dysfunction. Can you explain to our audience that whatever is done during hernia surgery doesn't actually affect the penis, like directly? Indirectly, maybe because of the anxiety or the pain that it may cause, but like functionally the blood flow and the nerves and the muscles are not related, correct? If that's correct, right?
Yeah, that's right. That's right.
I was a medical student.
No, so that's exactly right. I mean, the nerves are basically deep in the pelvis. So if you've had, they ride along the prostate. So any type of hernia surgery you have, you're not really in that area. The blood flow is down there as well. So you're not compromising any blood flow with hernia surgery. But the psychological component, it's very real. It's very real. And I would say, if functionally you're having good, strong erections, if everything works, the anatomy works in terms of the blood flow, nerves, and the hormones, that's very important. The last thing is, the psychological component is the way we'd attack that and address it. And there's so many good options for that as well.
So therefore, hernia surgery can never physically affect erectile dysfunction.
It should, no, it could be. Go ahead.
Complications such as I do a lot of like mesh removals, and the mesh may be eroded into like the spermatic cord contents. That also technically does not affect the penis or any of its components, correct?
No, I mean, it may affect the testicle, right? It may affect the function of the testicle, but then you have two testicles, right? So let's say you can make the argument, hey, listen, maybe it's going to affect the hormone levels, the testosterone production from one testicle, but you have another testicle that compensates for it. Any hernia surgery should not affect your sexual performance, your sexual drive, your erectile function. It shouldn't touch it at all.
I'm glad we cleared that up, because that question comes up on a weekly basis. And I just want to clarify that. That's very clearly said. And it's a real concern, because everything is so next door, nearby. But the origin of the nerves and the blood flow is totally different. And therefore, any hernia surgery, no matter how botched, cannot directly permanently affect penile function.
Erectile function. It may, there's some, the functional elements of an erection, it shouldn't affect it at all.
Right, that's what I mean. But now there's other issues. So the components, maybe you can kind of explain the anatomy. So in males, you have a testicle, actually you have two testicles. Plus there's blood flow and nerves and the sperm that's carried to the prostate. So those components, though, can be injured at the time of hernia repair. And that's what I deal with a lot, actually. We just did one 2 days? Last week. We just did one last week where it was a young kid. And, the mesh was like impinging on the spermatic cord. And so he had a lot of spermatic cord pain, testicular pain, in addition to groin pain. He had pain with intercourse, but an orgasm, but no pain with like ejaculation. So there's a lot that we discuss in my office, which is not typical for a general surgeon to talk about.
Right.
But maybe you can discuss the components of the spermatic cord and the testicle and how fertility may be affected if any of those go wrong.
Yeah, so the spermatic cord, there's a lot of expensive real estate there, in the sense of it's a lot of sensitive and expensive real estate, in the sense that it connects to your testicles, and because the testicles do the two things that it does, sperm and testosterone, if you compromise blood flow, if you compromise any blood flow to the testicle, you could potentially compromise sperm and testosterone production. That being said, when it comes to mesh, right, the things that could post-mesh complications around the spermatic cord, on the outside you have the detrusor, or you have the spermatic cord muscles, and those are basically those could be, if the mesh gets around them, you could have some type of spermatic cord pain, testicular pain as a result of it. You have the artery and you have the veins. If those blood flow gets compromised there, blood flow gets altered there, you could have some testicular issues in terms of pain, as well as functionality, again, sperm and testosterone. But more importantly, you have the vas deferens, right? And that's the tube that carries sperm from the testicle out into the prostate, into the urethra, and out into the real world. It's very thick walled. The vas is very thick walled, but sometimes what happens is, and I'm sure you could talk about this more than I can, it has to get compromised during surgery, right? But is that end all be all in terms of fertility down the road? Absolutely not. Absolutely not. First of all, you have two testicles, so you have another testicle that's going to naturally produce sperm, and all you need is one sperm in order to impregnate somebody. But more importantly, as long as the testicle itself is producing sperm, right? There's ways in which we could go in there and extract the sperm from the testicle and achieve a good or achieve the reproductive goals that you're trying to achieve. So there are options. Again, there's tons of options for this. Although there are complications with mesh, there's things we could do to address those without question.
So the natural way of having a child is you need to have testosterone, right? And then the sperm leaves the testicle, goes up the vas deferens, which is like pasta tube.
Yeah, it's like an al dente pasta. It's like that.
Pasta.
Remember medical school?
Yes.
Yeah.
And then it heads over to the prostate, correct?
Yeah, it goes into.
And what's the function of the prostate?
So the prostate and the seminal vesicles, basically they do a couple things. Number one, they create an environment, they provide nutrients to the prostate basically is involved in producing about 20% of your ejaculate. And within that 20%, it's nutrients, as well as it provides a basic environment for the sperm to survive within the vaginal area.
Okay.
The seminal vesicles, which are close to the prostate, that produces about 80%, 79%. And that produces a lot of same things, similar, basically gives a good environment for the sperm. So those three, the vas deferens, the seminal vesicles, and the prostate basically come together to produce your ejaculate.
So if you have mesh that's invaded or eroded into the vas deferens, which I see very commonly, it's possible that that tube is now blocked, right?
Yeah, absolutely, absolutely.
That would be the most extreme case. The most extreme case is there's either inflammation or erosion or bending or whatever of that tube to the point where the pathway from the testicle to the prostate and out the penis is blocked at the level of the mesh repair. So, but that doesn't mean you're infertile if you have one-sided hernia, correct?
Definitely not.
Yeah.
No.
Because you still have the other side.
You still have the other side, and more importantly, I mean, again, as long as you're producing sperm from that testicle, you're not infertile, because there's ways we could go in there and extract that healthy sperm, and again, achieve pregnancy.
And that's in vitro fertilization usually?
Yeah, I mean, if you're going into testicle, yeah, you have to do in vitro fertilization. Yeah.
Okay, so just to clarify that the natural way is for the testicle just to produce the sperm for it to come out through ejaculate. But if you can't do that because it's blocked for whatever reason, some people have vasectomy, right?
Right.
And
right.
that's why it's blocked on purpose. Others functionally have a vasectomy because of like mesh erosion or inflammation from surgery. You still have the sperm. So the sperm can be extracted directly from the testicle by a surgeon. Is that something you do, or are there other doctors that do that part of it?
No, so that's what I specialize in as male fertility specialist. That's, I mean, we could do vasectomy reversals, right? Yes. Where we reattach the two portions of the vas. That's more in a situation where you have a vasectomy, not in a situation with mesh erosion, just given the location.
Yeah.
But the sperm extraction, the testicular sperm extraction, that's what we specialize in. Yeah, absolutely.
Wow.
Yeah.
So we know that one of the major complications, I can't say complication because I'll call it a complication. One of the major side effects of doing hernia repair is you can get what's called testicular atrophy, which means the testicle shrinks down. Is that because it was an aggressive surgeon and the blood flow to the testicle has been compromised? Or why do people get so much testicular atrophy after, especially with open surgery? I don't see it as much with laparoscopic, but it's usually an open surgery operation. The testicle becomes like smaller and softer.
Yeah, I would say typically, if in a typical situation, the way you're describing it's because of blood flow, right? Basically, you're compromising. Typically, it's the arterial blood flow. Essentially, it's not getting the blood that it needs. The testicle's not getting it, and the way biology works, if you're not getting nutrients or if you're not getting blood and what you need to survive, you're going to atrophy. So that testicle will atrophy as a result of that. I don't know. I mean, I can't speak on how aggressive or open versus laparoscopic, but yeah, it's usually because you're not blood is compromised. That's the idea.
So if you have testicular atrophy, does that affect your fertility?
Bilaterally, potentially. Unilaterally, no. Okay. The beauty is we have two testicles, and there's a lot of I mean, we see it with pediatric urology. Sometimes what happens is an undescended testicle, if it doesn't drop all the way into the scrotum as a child, either that testicle, usually you have to take it out if it's too high up. But anyways, a lot of people survive, have a long, healthy sexual quality of life. Their testosterone levels are normal. Their reproductive potential is normal with one testicle their whole lives. So the other testicle generally compensates as a result of it losing the other one.
And part of what you do, you also give testosterone to males, right? I feel like in Los Angeles, the trend, like Sylvester Stallone's always bragging about the testosterone that he takes. Is that a thing?
Testosterone for men?
Yeah.
Oh yeah, I'm a big believer in testosterone for men, for sure.
Tell me more about that.
I mean, so testosterone, it's so important, right? And this is the problem with the idea of testosterone for men is this. It's in the 90s, there was a study that came out that basically said testosterone for men is not good because of risk of heart attack and strokes, right? And 90% of men, 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 90% And that was the
Okay.
first study that ever came out. Ever since then, there's been a black box warning on testosterone. It's a controlled substance. And ever since then, I believe there's been like 20 studies since then. And essentially every single one of those has disproven that initial study. And then when they looked at that initial study, they found out that there was a lot of messed up, there was women in the study, there was a lot of misinterpreted data. But ultimately, this is what we know about testosterone now.
Yeah.
If you look at a 65-year-old guy, or any, let's say 50-year-old guy, who has normal testosterone levels, you look at the same exact 50-year-old guy who has a low testosterone level, right? Yeah. That guy who has low testosterone levels, he's at increased risk of dying from heart attack, stroke, and overall mortality, right? He's gonna live a shorter life as a result of having low T. Okay. For a number of reasons, right? Because testosterone gives you energy, gives you stamina, gives you libido, gives you the drive to go out there and exercise, to have a social life, to spend time with people, all the good things. And more important, and also it's good for endothelial function, right? It's good for your body's ability to function. So I'm a huge believer in testosterone. I think it's important to get guys to normal levels, not to bodybuilder levels. Yeah. It just gets you to a normal level. And I do it for a lot of patients and they love it. They absolutely love it.
What if your testosterone level is normal? Would you give that to an elderly patient?
So it's a good question, right? So this is the problem. This is an issue here with testosterone too. So we say the normal range is 300 to 1,000, right? And which is a huge range. Yeah. My testosterone requirement is different than the guy next to me, and it's different than like an NFL player, for example. Everyone has different testosterone requirements. So the number is important. The number is important, but more importantly, the symptoms. When you have to. Some guys will come in. They're big guys. They're 6'5", 250, yeah. And their testosterone's at 500, and they still complain of low T.
Are they what? They're fatigued and kind of like overall.
Yeah, they're fatigued. They're not sleeping well. They're depressed. They're not. They used to exercise so much better than they are now. But now that when they start to exercise, they can't stand it. They're not there for more than 15 minutes. Mood issues. Erectile dysfunction, libido, those types of things. It's incredibly important. Testosterone is so important.
So I recently sent you a patient. He was young. Why was he on testosterone?
So someone put him on testosterone.
Yeah. Someone
else put him on testosterone. So for him, he
and you want to be off of it, right?
Yeah, I took him off the testosterone, put him on something that would stimulate natural testosterone production.
Oh, okay.
You could put, young guys, because this is the thing about testosterone also. I would, these clinics, a lot of clinics, they don't tell patients this. It's, if a guy wants to have a child, a young guy wants to have a child at some point in his life, you have to understand, going on exogenous testosterone, whether it's the gels, the injections, pellets, whatever it is, you're going to be sterile, right? You're killing your body's ability to produce sperm.
Oh.
And so a lot of guys will come in, they're like, look, I have no sperm. And it's like, are you on testosterone? They're like, yeah, I've been on it for 5 years. Like, no one ever told me that I can't be on it. So you have to take them off the testosterone. You have to put on some medications that essentially stimulate natural testosterone production. And natural testosterone production is good for sperm. So in doing so, you switch them off one and put them on another, and then they're able to do well.
So we have a question. What stimulates natural testosterone? What are you offering these people?
So it's the drug. There's a couple drugs, but essentially you're stimulating. The most common one that we use is something called Clomid. It's a fertility drug used for women, but we use it off-label in men. Very, very well tolerated. I have patients who have been on it for decades, who do great. It stimulates your brain to stimulate the testicles to produce testosterone.
That's pretty cool. Can surgery affect your testosterone level?
Yeah, you mean like hernia surgery?
Yeah, like some men come to me and they feel like after my surgery, I have dysfunction, I lost libido. I'm like, it's not from the surgery, but should I be sending them to you and having you check testosterone levels or stimulating their natural testosterone?
Yeah, so after surgery, for sure, guys will lose their testosterone, goes down after surgery, definitely.
Okay.
To what extent, it depends on the guy, and obviously depends on the surgery. But if it drops off, but most times it picks back up. Sometimes it takes months, sometimes it takes, 12 to 18 months. Yeah. But eventually it should get back to normal. But so yeah, to answer your question, definitely, people do have low testosterone as a result of surgery. Yeah. The more major the surgery, the lower the T.
We just don't think of these things, and then I talk to you, and then now I'm thinking of all these.
Yeah, you can send them my way.
Okay, let's go back to infertility and hernia surgery. So what do you know about hernia repair and actual infertility? Let's assume that we're talking bilateral now, left and right at the same time, because we already discussed that having one side of surgery can affect it. I'll tell you, historically, we didn't know. And then there was one or two studies that said men that undergo hernia repair, and this was during the tissue repair time, I think, and then maybe the mesh repair afterwards, their sperm counts are lower after hernia repair. And then that became one of the things, like you have to tell everyone that there's a risk of infertility after hernia surgery. Then a larger population study was done, and they said, no, there's actually no difference in sperm count, or actually, I think no difference in the ability to have children among those who've had a hernia repair and those who haven't. And that seems to be the consensus currently. What in your group, in your community of male health specialists, what do you say about, do they teach you anything about like hernia repair and as a cause of infertility?
I mean, we do know, I mean, there's some things that we discuss about. It's not a big topic, but, you know, to answer your question about that first study versus this one, I'd say I bet you, if you look at, you know, immediately after, or a couple months after hernia repair,
Yeah.
that vas deferens, that tube, there may be a little bit of inflammation around it, causing even a mild obstruction to that vas, causing decreased sperm counts. Now, the key thing here is this, and like you mentioned it, is at the end of the day, decreased sperm counts are one thing, but what's the goal? The goal is having successful pregnancy. So if you're able to say that after hernia repair, you're able to have normal or it's comparable rates of successful pregnancy, then there's no difference. Then you're good, right? That's the ultimate goal. So decreased sperm counts, I'd say, depending on when you're checking it, early, like a couple weeks after surgery versus a couple months versus a year. My sense is it shouldn't affect it at all. Long term, it shouldn't have any effect on sperm counts.
You know, I was sitting at the American Hernia Society meeting. This is maybe 10 or 15 years ago, early on in my career. And this surgeon came up, and I think he was from South America, and he took half the patients and did a typical Lichtenstein mesh-based open inguinal hernia repair. And the other half, he did the same operation, but he took the hernia sac, which is peritoneum, and he wrapped the spermatic cord with the hernia sac. And then he checked sperm counts afterwards, and the sperm count was lower in the pure mesh patients and higher than those in the those where it was like the spermatic cord was somewhat protected from the mesh. So I think you're right. I think it's the inflammation, at least in the short term, can affect it. Okay, so it's a short-term problem.
I think it shouldn't, long term, it shouldn't have any impact. If done appropriately, right? If the surgery is done well, then it shouldn't have any impact.
Yeah, we had this question, which I think you answered already, which was, would mesh cause erectile dysfunction and the inability to maintain an erection if the mesh erodes or shifts somehow? Yeah, so if you have erosion, besides the pain, I guess the pain would affect the erectile dysfunction?
I mean, the pain, and then the pain associated with knowing that you're going to experience pain during sex, during intercourse, that may, as a result, that may lead to erectile dysfunction. But again, functionally, it has no effect on the anatomy and the important components to have an erection. No impact.
And then if there is damage to the spermatic cord, and by damage, I mean erosion, let's say, is that a reversible problem?
So it depends what part of the spermatic cord. So let's say the mesh erodes into the outer portion. So let's say it erodes into the spermatic cord peripherally, right, on the outer portion, into the muscle fibers, and that leads to some level of testicular pain. Now, it may not be reversible, but if that's leading to pain, there's things that we could do to stop and to prevent that. It's called we do a spermatic cord denervation. So we look under a microscope, it's very, we identify all the portions of the spermatic cord, and we're able to essentially isolate the parts of the spermatic cord that could be leading to pain. We burn those areas. We make sure that those nerve fibers are no longer conducting and causing pain. So in that sense, it's reversible in terms of pain. Now, let's say an artery is compromised. At that point, there's very little you could do, especially after surgery, in terms of revascularizing that testicle. If we talked about the vas, if the vas deferens is compromised, whether it's blood flow compromised or it's actually cut that high up, there's very little you could do in terms of reversibility of it. And then the veins, even if you compromise some of the veins, you may get a varicocele. You may get like varicose veins of the testicles. You may potentially get that. And there's things microsurgically we're able to go in there and address that as well. So in some ways there are, it's reversible isn't the right way of saying it, but it's more there's solutions to it. If there is a problem caused by it, we have some options available.
So there's this gentleman that's been following me for years. He's seen, I would say 10 or 15 surgeons. They're all on the East Coast. For some reason, he's not asking to be seen by anyone on the West Coast, which means I haven't been able to help him. But he's seen many of the experts that I put on HerniaTalk Live. So here's his issue. He had, I don't know if it got, I think his nerve got cut. The genital branch of the genitofemoral nerve got cut. We know that that gives sensation to the scrotal skin, but it also is the nerve that feeds the cremasteric muscle. So as a result, he has kind of like a low-lying testicle. What is there a treatment for that?
You mean his testicle essentially it's hanging much lower than the other one?
Yeah.
Is there a proven? You could go in there and figure something out, right? You could. Let me before actually.
The cremasteric, do a cremasteric pull-up.
No, because once that muscle fiber is denervated, the nerves to that muscle are gone. There's very little to do. There's very little you could do to stimulate that muscle to go back up. Now, the problem is that the testicles, the thing about the testicles is they're very temperature sensitive, right? For them to function, for them to produce sperm, for them to produce testosterone, they live within this very narrow temperature range. And that's the whole point of the scrotum, right? The scrotum, when it gets too hot, your scrotum relaxes and it takes it away from the body. When it's cold, your body pulls them up, right? Because it wants to stay, again, within this narrow temperature range. Right. So if you mess with that, now if you mess with that by tacking them too high up, you're going to decrease testicular function because you're too close to the body. It's going to be warm. So no, there's no real good option for it. No, there's not.
I'm telling you, the Erodes Clinic, which is a hospital in Toronto, outside Toronto in Canada, they do hernia surgeries only. Almost all of it is inguinal and it's tissue-based. So based on the Erodes technique, they routinely transect the cremasteric muscle. They do it because they found that by doing that, they reduce their recurrence rate. And as a result, the testicle can drop. So as part of their repair, at the same time as cutting the cremasteric muscle, they sew it up to the pubic bone.
They sew the cremasteric muscle to the pubic bone. And just let it kind of hang from there.
Hang there. Does that sound like a good idea?
I
would say leave good enough alone. I don't know.
So look, when we do the cremasteric, when we do the denervation, we're releasing all the cremasterics and we're just letting it hang, right? Yes. We're not really attaching it to anything. But to attach it, I'll say that, if they haven't had any problems, I don't think it's a bad idea. Especially if they're not having problems. But I wouldn't necessarily do it. It's an extra step. It could create problems. Yeah. There's nothing wrong with just letting it hang, right? There's absolutely nothing wrong with that.
But then won't it hang too low or no?
Yeah, but your scrotum supports it.
Oh,
your scrotum supports it. Yeah.
But I've seen men that have kind of like
I know. I have
denervation of the cremasteric muscle from the genital, and then one testicle's super low.
Right. And I have too. And most guys are okay with it, but some guys complain.
Yeah.
And there's things you could do. We call it orchiopexy. You could pexy the testicle a little bit higher. It's more of a
Okay.
cosmetic procedure. There's no, the aesthetics of it are usually the reason why guys are bothered by it. But yeah, there's things you could do for it. There's things
If
you
you have cremasteric dysfunction, can that cause testicular pain?
definitely.
I think that's what this guy has then.
Yeah, definitely. That when that cremaster is hyperactive, sometimes
Yeah,
it's moving way too high or it's hanging too low.
right.
Just that movement, that friction could cause pain.
And what's the treatment for that?
I'd start with a spermatic cord block.
Okay. Yeah,
Yeah.
and see if any of the nerves are involved.
Yeah, and if the spermatic cord block works, then denervations are great for these guys with cremasteric dysfunction.
Yeah. See, I'm sending you so many difficult questions.
No,
Because these are not questions that you can read in a book or in a journal. These are not questions that, come up routinely. And then these poor patients, they are kind of left out there. And I feel that a lot of doctors they have a hesitancy to commit to an answer, and then the patient is at a loss,
right.
you know?
Okay, you're right. There's no textbook to this stuff. Not at all.
No.
Not at all. Yeah.
Okay, couple questions. A quick one here. 6 months ago, I had inguinal hernia surgery with mesh. I noticed this is laparoscopic, by the way, laparoscopic bilateral inguinal hernia repair with mesh, which I must say has a lower risk of vascular, like blood vessel injury to the testicle than open surgery. I noticed a change in my urine smell. It almost smells ammonia-like. I've gotten urine tests which are normal. Is there any chance the mesh or the operation could cause a change in my urine odor?
When was the surgery? How many months ago?
6 months ago.
Huh. Interesting. And as long as
Why would urine smell like ammonia?
I mean, I'd say the smell of urine, a lot of it, it's diet and hydration dependent.
Okay.
If the diet has changed in the last 6 months, potentially, and the hydration status. But as long as so we do something called the urinalysis, and basically it looks at a few of the important things of urine. As long as that's fine, I wouldn't be worried. I wouldn't necessarily be worried.
Could antibiotics, so if you give antibiotics, like during surgery, we gave 1 dose antibiotic. There's this thing called SIBO. We had this whole hour with Dr. Trezon, a gastroenterologist, about SIBO, which is small intestinal bacterial overgrowth. So you give antibiotics, it changes the bacterial flora in your colon. Some bacteria are killed, and then the other ones therefore survive and become much more popular. And that increase in population of that bacteria can cause bloating and gas, a lot of problems. Can that happen with urine? Can it change urine is sterile, but is it possible that antibiotics can change the pH of urine? I don't know. I'm making these things up.
No, it's a good question. So, there's it's about a year ago, I read something about this where, so less so like SIBO, obviously, you have a ton of bacteria in your GI tract, but the bladder itself, there's something called interstitial cystitis.
Yes.
Where there's a bacteria, we're realizing there's a bacterial component to it. There's good bacteria, there's good healthy bacteria that just keep the bladder wall healthy. So, taking antibiotics, definitely, basically patients who have recurrent UTIs, they're more prone to interstitial cystitis or bladder pain because that good bacteria is always being destroyed.
Yeah.
So, taking 1 dose of intraoperative antibiotics and a few days of antibiotics after surgery shouldn't, cause that.
Yeah.
It shouldn't cause anything that long-term to the bladder wall. But chronically, antibiotics could definitely cause that.
Are there other tests besides a routine urinalysis that can analyze content in your urine?
Yeah. I mean, there's things we could do we have advanced tests now with PCR, using PCR, where we're able to identify even the smallest amounts of various bacteria within your urine, within your prostate. So yeah, there is but usually if you're having an issue where bad bacteria are living in your urinary system, you have pain, right? That's the simplest thing is pain. If you're having pain with urination, but if it's just the smell, it's no pain. I'd say it's okay. But if it is bothersome, that we could do advanced PCR tests to figure that out.
During laparoscopic surgery, I and many other surgeons, we place Foley catheters, and that can introduce bacteria, not anything to cause an infection necessarily, but bacterial prostatitis or some type of prostatitis is a side effect, right, of Foley catheterization. Is that true?
If the catheter sits there for
A long
a little bit, if it sits
You
there.
can't get prostatitis from just in and out.
No, I mean, you may get a
hours.
UTI, you may get a urinary tract infection, but prostatitis usually comes after that.
I was wondering if that was the cause, if it's a prostatitis issue. I guess not. I'm trying to figure out this poor guy's problem here.
I mean, doing the PCR, I think doing that PCR test could probably help him, at least to see if maybe there is a bacterial source to this.
Yeah. So we have Tracy Scher, who's a great pelvic floor physical therapist. She writes, I'm a big fan of pelvic floor PT, manual therapy, and bulbospongiosis, spermatic cord, and that whole area before blocks and denervation. What are your thoughts about that?
I'm a huge fan of pelvic floor physical therapy. I think it's incredibly important. That whole area, I think she's right in the cremasteric. So that patient that you were talking about who may have cremasteric overactivity, a lot of times it's that pelvic floor, because it's essentially attached to the pelvic floor. It's the thick pelvic floor muscles, and people don't appreciate the pelvic floor muscles. Some of it's voluntary. These are the muscles that we use to stop our urinary stream, for example, when we're urinating, but they're involved in urination, defecation, ejaculation, and they're very, very strong muscles. So if there's ever any dysrhythmia to them, it could cause problems. So the cremasteric, that patient for cremasteric issues, if they are, pelvic floor physical therapy could definitely relax that pelvic floor. To the extent of releasing that cremaster, I don't know, but it's a great idea, 100%.
So for men, pelvic floor PT, does that involve rectal manipulation?
Yeah, it's all rectal.
That's awesome, no?
But patients love it.
It's a little odd, no?
Which part?
Just to initiate pelvic floor PT for men. I feel like women, it's transvaginal for women, so it's a little bit more tolerated. I don't know. What are your thoughts on that?
So I've sent many patients to pelvic floor, and none of them actually have come back and been like, I don't like that.
Oh, okay, good.
They get good results. Pelvic floor PT is very underrated. It's wonderful.
Good to know. Okay, another question is, what is more important in determining how high or low the testicle lies? The scrotum supporting it or the cremasteric muscle function?
It's a good question. They work hand in hand. They work in harmony, right? It's not like the cremaster is going to release and then the scrotum is going to pull up. But what I would say, I think that the stronger component is it's the scrotum, because the scrotal muscles are definitely thicker. So when we operate down to the testicle, when we go through the scrotal muscles, they're definitely thicker. I mean, it's markedly thicker than the cremasters of the testicle. So I would say the scrotum is the bigger component.
Yeah, very cool. Tracy said that when she does the pelvic floor PT for men, it can be external too, and 60% of her patients are men for pain. Wow, so Tracy, 60% of your population are men? That seems discordant. I would have assumed mostly it would be women, or I don't know. Do you find that pelvic floor PT for men is being more commonly prescribed now than before?
Yeah, because so what happens is a lot of these guys, they'll get prostatitis and they'll sit on it, right? And they won't do anything about it, or it lingers on.
Yeah.
The prostate sits right in the middle of that pelvic floor. So that inflammation, once it spreads to the pelvic floor area, those muscles are gonna, they're going to be firing and causing a lot of pain.
Yeah, you know, the pelvic, I had to learn more about the pelvic floor because I kept hearing that my patients would present with these occult small hernias, you know, little inguinal hernias. But their main complaint was they urinate 10 times a day. They wake up at night multiple times a day. And it just seems that that was just odd. They fixed their hernia and then the urination went fine. So we kind of decided that pelvic floor spasm is one of the side effects of having a hernia, especially the smaller ones for some reason. And so rectal pain, tenesmus, urinary frequency, and sometimes incomplete bladder emptying, but usually the frequency and urgency is part of the questions that I ask my patients just to kind of get a better understanding of how the pelvic floor is involved. And however, pelvic floor PT, though it can help the spasm, in patients with hernias tends to hurt more. And then I feel like that's one of the deciding factors in determining if the hernia is the cause or not, is they don't tolerate pelvic floor PT as well. You fix the hernia and then they tolerate it much better. Oh, Tracy's giving us some more information. So she specializes in complex pelvic pain, pudendal, testicular pain, etc., which of course can affect the men. She also makes a comment that prostatitis gets diagnosed, but then often it's actually related to pelvic floor issues at any level and gets missed often. So that's essentially a label, but not the underlying issue. I would agree. I feel that male chronic pelvic pain equals prostatitis in so many people's charts, and
Pelvic floor.
it's not necessarily that, right?
For sure, yeah. Pelvic. I mean, I'm a huge fan of pelvic floor physical therapy. It's great. A lot of good outcomes.
And we're lucky in Los Angeles, we have great pelvic floor PT, but it's like your specialty. It's one of those specialties within physical therapy that is growing, but there aren't that many people around that do them. Another question for you. I had ascension of my testicle following tissue open repair. So this is inguinal hernia repair without mesh, and was checked both on exam and by MRI with no evidence of recurrence. Is there anything urological other than recurrence that could cause elevation of my testicle? I know the answer to that.
So they had an open repair and
Without mesh, and now they have a high riding testicle.
What I would think of just off the cuff, I would say it's one of two things. Maybe the cord was potentially sutured or placed a little bit higher when they were closing the hernia area. Or what could happen is sometimes scar formation, right?
Yeah.
That scar formation, that healing area of the hernia will, if it scars down higher up on the cord, then it's going to sit higher.
Yeah, I agree. So whenever we do inguinal hernia repair, I always make sure the testicles, at the end of the operation, testicles pulled down into the scrotum, because no matter what operation you do, there will be scar tissue, and you don't want the testicle to scar in an elevated position. Okay, the clarification on the last question. The high riding testicle is only during ejaculation. Why is that?
So, so what happens is, like as Tracy alluded to with the pelvic floor, so it's all kind of connected, right? The pelvic floor and the cremasters, they're all in some way connected. So what could happen is it shouldn't usually happen, but it does sometimes. When that pelvic floor, as I mentioned, the pelvic floor is responsible for orgasm and ejaculation. When that pelvic floor is contracting in order to emit, in order to ejaculate, sometimes that's transmitting to the cremasters, and when they contract, they pull up. So, so that would explain
That's normal.
To a certain extent. To a certain extent.
I mean, hyperactivity.
Well, I think a lot of guys don't pay attention to it, right? They're not paying attention to it to know whether or not if it's happening or not. But I would say it's normal to a certain extent for sure. But if you're having pain with it, then there's things we could do. But as long as there's no pain, it's fine. I wouldn't worry.
Completely normal. Okay. Yeah. But why would it happen after surgery? Is it just they're more aware, or?
That area. That's a good question. I'd say just that area is just hyperactive.
Yeah.
Sometimes because of scarring, because of the healing, sometimes those nerves to that area are just a little bit more active, a little bit more reactive, so they're hyperstimulated.
Yeah. In fact, so with ejaculation comes orgasm, and that does kind of cause extreme kind of contraction. I wonder if could you have kind of a hyperactivity of the genital nerve because it's being impinged on?
Yeah, true. That's a good point, actually. It could be a nerve issue that's causing that. Yeah. A hyperactive nerve
I
could
have a long
basically
one here.
stimulate that.
Let me read this for you. I had an inguinal hernia repair bilateral almost 6 weeks ago. My last operation prior to that was in 2012. I had an inguinal hernia recurrence. This time, the same operation had to be done. Now the third time for inguinal hernia repair. Only that I had on the right side an inguinal hernia as well. But now after surgery, after being in bilateral chronic pain for 2 years, I have a great pain of the lumbar upper abdomen and the right. It radiates to my right leg and my right epididymis. So it sounds like the left growing pain is gone, but my body still suffers on the right. Is there something I can do? Maybe we can talk about epididymis and epididymitis. Can you explain what the epididymis is and
Yeah. So
it gets inflamed?
the epididymis is it's underappreciated. So the testicle, there's two structures within. I mean, the testicle isn't just by itself. Posterior, laterally, like behind and a little bit to on the outside, there's this structure that basically rides along the whole thing from the top to the bottom.
Yeah.
And it's very important because what happens is it's the connection, it's the in-between between the testicle and the vas deferens that we talked about. So what happens is the testicle produces sperm, the sperm go into this epididymis and they work their way. So the testicle sperm goes up, then all the way back down. Through the epididymis is when they mature, right? That's when they become adult forms and ready to go out there and procreate. And they sit in the epididymis, and when you're ready to ejaculate, all that comes up through the vas deferens and into the outside world. And that usually takes 71 days, right? We say about 70 days for sperm from the day of production to the day of ejaculation, about 70 days. So the epididymis, it's important, and it has issues with it. Sometimes there's bacterial issues with it, where you get bacterial inflammation of it. Sometimes it's overuse inflammation. You get you use it too much and it causes pain and you get inflammation as a result of it. Those are the two main ones. Now, I think she's referring to a nerve issue associated with it, right?
Well, let me tell you this. I get patients where they have an obstruction at the hernia repair, but there's no pain up there. What they actually have is epididymitis or very swollen epididymis and also spermatocele. Maybe you can explain why that happens, because I feel that they go to urologists keep giving them antibiotics for their epididymitis. What they really have is an engorged epididymis and even leakage because there's an obstruction higher up at the level of the hernia repair.
Interesting. They'll get spermatoceles after hernia surgery.
Mm-hmm.
Really?
Yeah.
That's interesting because look, the thing is, the reason why I say it's so interesting is because we do the vasectomy, right?
Yes.
And we're doing it much closer to the testicle.
Yes.
You would think that the obstruction would be even more severe.
Yeah, I never understood why vasectomy doesn't cause obstruction side effects, but erosion, maybe it's not completely closed.
It's a different type of. I think there's more. It's more than just the vas that's being affected.
Yeah.
During the hernia. So to answer your question about the spermatocele, it's the spermatocele. It's a cyst. It's a cyst of the epididymis where those tubules that basically carry the sperm, sometimes they get an outpouching, and the sperm will grow in that outpouching. So what is usually something small will slowly grow in size. Is it bad? Absolutely not. Does it affect fertility? Definitely not. Sometimes guys are bothered by the growth and the size of it. So at that point, you could go in there and surgically remove it. But it's generally benign and it doesn't have any long-term issues with it. But that's very interesting that you get the spermatoceles when you're that high up.
Yeah.
I have to think about that. I wonder what causes that.
I don't know. And then they get what is it called? They get epididymal
Epididymal orchitis.
No, what is it when you do the bypass? You kind of connect it over.
Vasoepididymostomy.
Open. What is it?
Vasoepididymostomy.
Yes.
They'll get one of those.
Yeah, and it cures.
Really? Yeah.
No,
Well, I mean, look, the cure part, that makes sense. No, the cure, because it's obstruction. No. To answer your, I get the cure part, but to connect those from, to make that connection, that's a pretty good length that you're traversing.
Yeah.
But it's an obstructive process. Yeah.
Yeah. Okay. Does varicocele affect fertility?
Definitely. Yeah, definitely. So the way to think about varicocele is, like I said, it's varicose veins. So what happens is, blood pools around the testicle. Blood is generally very warm. Testicle likes to live in a very narrow temperature range. So when blood is pooling, warm blood is pooling around it, that testicle is not going to function the way it's supposed to.
Yeah.
So it does cause decreased sperm parameters. Typically, you get varicoceles on the left. They're much more common on the left versus the right. Very common. Varicoceles are very common. I do a lot of these surgeries microsurgically. We go in there and we ligate those veins. We tie off those veins and prevent that back pooling. And usually you see a recovery in sperm in about 4 months.
Does spermatocele affect fertility?
No, it shouldn't. It really shouldn't. If addressed appropriately, if you tie it off, if you basically find it at its base, you're able to reestablish the natural connection, the natural flow of sperm.
Okay. Another question. Do you advise follow-up after hernia surgery with Dopplers or testicular ultrasonography? That's not routine.
Yeah, well, if you're not having pain, no, there's no reason to. No.
Yeah, it's definitely not routine to do any imaging after your hernia surgery.
No.
But if you do have testicular pain, the first step is examination and always include a testicular ultrasound, because there's a lot of things that can go wrong regardless of the hernia surgery.
Exactly.
Unrelated to the hernia surgery. But I think things that higher up than the testicle, which is the hernia repair, definitely should be looked at. And I feel that a lot of times patients have had a hernia repair, and because all their symptoms are not in the groin where the hernia repair was, but down lower in the testicle, people forget that the origin can be up higher in the groin region.
Right.
Let's see. Do injured or cut nerves heal with time? I had an inguinal hernia repair with mesh removed 5 months, but it's hardened inside me. Ilioinguinal nerve was sacrificed when mesh was implanted. Yeah, nerves do heal, but sometimes they heal abnormally about 5% of the time, like a neuroma. So you gotta be careful anytime you cut nerves. Sometimes we have to cut it, but not. What about mesh migration in the body? I don't know what the question is about. Mesh doesn't usually migrate. It's usually gets stuck immediately where it is. Plugs have been shown to migrate sometimes, but mesh doesn't usually migrate.
It sits there, secure.
Misconception. Okay, well, I know that you and your group are the esteemed group of urologists in Los Angeles. That's why I work with you all. And so I do appreciate all the work that you provide for the care of my patients. If someone wants to see you in consultation, how can should they just go on social media and DM you, or because you're young, hip, and happening, or what do they do? Do you have an email address, website?
Yeah, so I mean, a couple of ways you could do it. You could either call the office and schedule a consultation. You could look me up on Google. I have a Google page, Justin Houman, Houman, MD. And then I have a social media presence where I talk about a lot of men's health issues, from low testosterone, erectile dysfunction, fertility issues, low libido. But across any of those, whether you look me up on Google, call the office, or even the social media, you want to slide it, you want to send a message through the direct message on Instagram or Twitter, what have you, I'm happy to respond.
So a lot of thank yous out here. Thank you for your time and expertise. Are patients that are out of town, would they benefit from seeing you? Like, let's say they need fertility help. Is that something that works? Like if they come and fly in to see you?
Absolutely. I mean, I do telemedicine for a lot of out of state patients.
Yeah.
Depends on what it is. Like, you can't do a vasectomy if you're out of state. You can't do a vasectomy, obviously, over telemedicine. But fertility issues, hormone issues, and erectile dysfunction, We find ways in which to coordinate. Most of the time, we easily do it through telemedicine, but sometimes we do need to do an in-person consultation.
Actually, that's a good point about vasectomy. They can travel, and do you as a specialist recommend that vasectomies be done by someone like you rather than a general urologist? Would they have less risk of, let's say, post-vasectomy chronic pain?
I would
want you to
say,
toot your horn.
obviously my answer, I think come to a mental health specialist, but in general, the idea is vasectomies, all urologists are very well versed in, or most urologists are very well versed in doing a vasectomy. And, if you have a
general surgeons and doing hernia repairs.
there you go, right? Yeah. So it's, most people are very well versed in it and they do a good job with it. So yeah, you can go anywhere really.
All right. Well, thank you very much, Dr. Houman, for spending your evening with us. This is the end of Hernia Talk Live. Please do follow Dr. Justin Houman, MD, on Twitter and Instagram. I'm at HerniaDoc on Twitter and Instagram. Thank you for all of your questions through Facebook Live at Dr. Towfigh, and for all of you joining us on Zoom. I will post the link to this talk from my YouTube channel, and hopefully you can like it and share it and watch it over and over again. And I feel like more men need to watch this and see how complicated it can be. But when you see urologists or specialists that only do this kind of work, it really makes it much more likely that you'll get excellent care. So thank you, Dr. Houman, and I'll see you at the hospital.
Sounds good. Hey, thank you. I really appreciate the opportunity. Thanks a lot.
Patients. They've been very happy, and hope you have a good rest of your evening.
Likewise. Thank you. Take care.